Hello friends, I am Dr. AVNISH GOEL, a senior consultant dermatologist and aesthetic laser surgeon. Hello friends. Having post-MD experience of 15 years, I am an educator and orator in dermatology, STD, lasers and aesthetic procedures, and I have more than 25 publications in my name. So let's crack NEET PG on with India's largest learning platform, that is Unacademy. So what will you get in Unacademy? So you get daily live classes. So you get daily live classes, then structured courses will be there. You get live tests and quizzes, and you get unlimited access to whatever contents you have on the Unacademy platform. So we are going to start a revision batch course for FMGE 2020. So you can enroll for that, and the concise batch course for NEET PG 2021. So you can also enroll for that. So the revision batch course for FMGE 2020, it is starting on April 16th. And the concise batch course, it has already been started on the April 13th. So these are the subscription rates. 1 month subscription for the courses. The NEET PG course will cost you somewhere around 4,500 rupees. And if you use the code which is being projected below, if you use my name Dr. AVNISH-YT, then you will get additional 10% discount on the subscription. So now let us start the MCQ, match the following types MCQs in dermatology, and here is your first question. It says deficiency of following match the following deficiency diseases with their corresponding cutaneous changes. So for the given question, the deficiency diseases with pellagra. So pellagra, it is associated with the gauntlet sign, is it not? You get the gauntlet sign in pellagra. Copper deficiency, it is associated with Kenkes hair. Then riboflavin deficiency, it is associated with angular cheilitis, and essential fatty acid deficiency leads to phrinoderma. So this is the correct arrangement for the given question. So pellagra may lead to the gauntlet sign, that is quite characteristic of pellagra. Then copper deficiency, it leads to the Kenkes hair. The riboflavin deficiency, it leads to the angular cheilitis, and essential fatty acid deficiency, it leads to phrinoderma. Now coming to the discussion, I'll show the clinical images of few of them. So these are the gauntlet signs of the pellagra. Apart from dermatitis, diarrhea, dementia, and finally death, you get the cutaneous manifestations in the form of this gauntlet. So it is an ornament, usually the tribal people they wear. So these are called as the gauntlet, and these are seen, the gauntlet of pellagra, it is seen as a manifestation of niacin deficiency or tryptophan deficiency. So it is a manifestation in pellagra. In the ariboflavinosis, the riboflavin deficiency, it is associated with angular stomatitis, glossitis, and cheilosis. So all the things are there. So angular stomatitis, it is quite characteristic of riboflavin deficiency, though it can be there in the candidiasis also. Then these are the various tongue changes in the vitamin deficiency. You get the magenta red tongue, in the riboflavin deficiency. You get scarlet tongue, in the niacin deficiency, and beefy red tongue in the vitamin B12 deficiency. So these are the various tongues, the appearance of various tongues in various deficiency disorders. Then coming to the copper deficiency, the copper deficiency, it is called as the Menkes disease, and they are associated with Kenkes hair. So otherwise it is also called as Menkes disease. So Menkes disease, it is the hereditary condition caused by the defective gene that is involved in the metabolism of copper. So the gene is involved, that is a defective metabolism of copper that is there in the Menkes disease. The other features which includes, apart from the Kenkes hair, the floppy muscle tone, the child is floppy, it is associated with seizures, abnormally low temperature, and you get the particularly steel color of the hair. So the hair changes are very much characteristic of this Kenkes disease, and it is usually fatal within first 10 years of life. So the Kenkes disease, Menkes disease, they are associated with Kenkes hair. So these are various deficiency disorders associated with various food ingredients. So you know the phrenoderma. The phrenoderma, it is classically seen with vitamin A deficiency. So this is a very classical, but apart from vitamin A deficiency, it is also associated with free fatty acid deficiency. It is also associated with vitamin B and E deficiency. So vitamin A, B, E and essential fatty acids all are responsible for the development of phrenoderma. So in the phrenoderma, you get the follicular hyperkeratosis around the hair follicle. You get the lesions like this. So these are around the hair follicle. In phrenoderma, you get the night blindness. So that is quite characteristic. Inability to see in bright light. You get xerophthalmia. That is the dryness of conjunctiva and cornea. Bitoid spots are seen over the conjunctiva. So these are gray-white patches over the conjunctiva. Keratomalacia is drying and clouding of cornea, delayed growth and mental retardation. So in total, you get the more of the eye changes. You get the hyperkeratotic papules or follicular papules in the skin associated with delayed growth and mental retardation as a manifestation of phrenoderma. And I want you to know once again that the phrenoderma can be a manifestation of vitamin A deficiency, that is quite common, but otherwise it could be due to vitamin E, vitamin B and essential fatty acids. So this is the various cutaneous changes due to the deficiency disorders. Now coming to question number 2. Match the following characteristic feature of skin lesions with their diseases. So you are having the 4 characteristic skin features and you have to match them with their skin diseases. Yes, anybody who wants to answer it? Yes, anybody who wants to answer the question? So, if there is no one, I should tell you the correct answer. So, you get monomorphic lesion, thus lesions of similar morphology. So, all the lesions will be of similar morphology. You get them in acne estivalis. Then satellite lesions, they are quite characteristic of candidiasis, though they are also seen in BT Hansen's. Then polymorphic lesions, multiple morphology of the lesions, you get them in acne vulgaris. You get them in acne vulgaris. And pleomorphic lesions, they are quite characteristic of varicella and herpes zoster. So monomorphic lesions, you get them in acne estivalis or the steroid acne. Then satellite lesions, they are characteristic of candidiasis among the following choices. Then pleomorphic lesions, they are seen in varicella, and polymorphic lesions, they are seen in acne vulgaris. So these are the characteristic skin lesions with the characteristic skin lesion with the diseases. So these are monomorphic lesions. So monomorphic, it means the lesions are of similar morphology, as you can see in these images. So the lesions are of same morphology. So these are in acne form eruptions. So these are not true acne form, they are acne like eruptions. So acne like eruptions, you get them in steroid acne when they are induced due to steroids, and acne estivalis when they are induced due to sun exposure. So monomorphic lesions, they are the acne form eruptions. So they can be seen in acne estivalis or the acne which develops secondary to sun exposure, as well as the steroid acne. So these are acne estivalis and steroid acne showing the monomorphic lesions. Then you get satellite lesions. You get a smaller lesion in the vicinity of a larger lesion. So this is a smaller lesion and it is in a vicinity of a larger lesion. So these are satellite lesions of BT Hansen's. Similarly here you get a smaller lesions in the vicinity of a larger lesion. So this is the satellite lesions of BT Hansen's. You get similar satellite lesions, the smaller lesions in the vicinity of larger lesions. So these are seen in candidiasis. So these are the satellite lesions of candidiasis. You get polymorphic lesions, so multiple lesions at the same time, multiple morphology of the lesions at the same time. So they are quite characteristic of acne vulgaris. So acne vulgaris has got polymorphic, multiple lesions, multiple sort of lesions at the same time. Then you have pleomorphic lesions. So the point I want you to know that the pleomorphic lesion, it represents the different stages of evolution. So in a varicella patient or on a herpes zoster patient, it starts as a papule, then it goes to develop a vesicle, then pustule, then it ruptures to form crust, and finally a scar. So there will be different stages of evolution in a single patient. So they are called as the pleomorphic lesion. So different stages of evolution, they are the pleomorphic lesion. They are the pleomorphic lesions. They are very much characteristic of varicella, that is the chickenpox, and herpes zoster. Then you get the flat top lesions that are quite characteristic of lichen planus. So the lesions of lichen planus, they are purple, polygonal, flat top, pruritic, and they are very much characteristic of lichen planus. So these sort of lesions are there in lichen planus. Then umbilicated lesions. Among the umbilicated lesions, you get the umbilicated papules. So lesions, when it is mentioned as papules, umbilicated papules, they are characteristic of molluscum contagiosum. So whenever the papules are there, it is characteristic of molluscum contagiosum. And umbilicated vesicle. So if the question says about the vesicle, then it is characteristic of varicella, and it is characteristic of herpes zoster. So these are the lesions, the sort of lesions and their arrangement with the diseases. Now question number 3. You said 4 is A, that is correct. But what about others? Three is D. Okay, that is also correct. Well, you get half and half nails. The half nail is white, half is normal. You get them in renal failure. Then the tarry nails, they are characteristic of liver failure. The fine pits, they are seen in alopecia areata, and the oil drop sign, that is quite characteristic of psoriasis. So you know that 2, you gave it correctly. So 2 is B. Sorry, the 2 is C. So Yash says A is C. So I'll come to the discussion. I'll show you the images. So half and half nail, you know, the half nail is white, half nail is normal. So these are called as half and half nail. They are also called as Lindsay's nail. The proximal portion will appear white, while the distal half will appear red, pink, brown. So there is a sharp line of demarcation between the two. So you know that the proximal portion is white, and the distal portion, it can be pink, brown, white, or it can be normal, and it is characteristically seen in the patients with renal failure on hemodialysis. So this is half and half nail. About the tarry nail, whole of the nail will be having a ground glass appearance. So whole of the nail will be white. So fingernail and toenail appear white without any lunula. So this sort of structure in a normal nail is called as lunula. So you know that in such sort of nails, even the lunula may be absent. So the nail will have a ground glass appearance, and it is seen in the patients of the liver failure, diabetes, congestive heart failure, hyperthyroidism, and malnutrition. So you know the tarry nails, they are more commonly associated with the liver failure. Then these are the pits. The fine pits are characteristic of alopecia areata, and the coarse pits, they are associated with psoriasis. So fine pits, the Scotch plaid pattern, Scotch plaid pattern, the multiple small pits, they are very much characteristic of alopecia areata, and the large coarse pits, they are seen with psoriasis. This is the first image, shows the oil drop sign in psoriasis, and this is due to the involvement of nail bed. So the nail bed is having the psoriatic feature, and that nail bed feature will appear through the nail plate as a red patch, salmon color patch, or a oil drop sign. So otherwise you can see this subungual hyperkeratosis in the patient of psoriasis. You can see the salmon patch. So all these, the oil drop signs, subungual hyperkeratosis, nail pitting, coarse pitting, so they all are characteristic of nail psoriasis. Now the Bewes lines, they are the central indentation over the nails, so they are an indentation in the nail. Then the nail changes in lichen planus, you get the pterygium of the nail. So that is the involvement starts in the nail bed, somewhere here it starts. Then there will be involvement of the nail matrix, and a skin fold. This is a skin fold will come and join with the hyponychium. So this point is hyponychium. So skin fold will come and join with the hyponychium, and it divides into the nail into two parts. So this is dorsal pterygium, and it is very much characteristic of lichen planus. Then you get a pup tent sign. Pup tent sign, it is due to the involvement of the nail bed with lichen planus. So you get the nail bed being involved with lichen planus. So development of a papule in the nail bed, it elevates the nail both laterally and longitudinally. So that is a pup tent sign, and it is a feature of lichen planus. Then you get the trachonicia, that is the rough nail. You can see the trachonicia of the nail that are quite characteristic of lichen planus, though they can be seen in other conditions. This is subungual hyperkeratosis. Below the nail plate you get the hyperkeratosis. So these are again characteristic of lichen planus. So you get Wickham's striae. This longitudinal striations, they are due to Wickham's striae on the nail. The Wickham's striae in the oral cavity, it presents with the white reticulate pattern of the oral lichen planus, and Wickham's striae on the body, it presents, it must be seen as the white lacy pattern over the parts involved with lichen planus, and best seen with the mineral oil application. And this image shows the violaceous lines over the nail plate as well as the pterygium. So all these changes are associated with lichen planus. Now again the trachonicia is being shown here. The rough nail is being shown. It can involve all the nails. It can be there in one or two nails. Then I would like to tell you that the dorsal pterygium, which is quite characteristic of lichen planus, it is also seen apart from the lichen planus, it is also seen in the burns, in the patient with burns, with cicatricial pemphigoid, disc keratosis congenital, graft versus host disease, radiodermatitis, and SLE. So these are the conditions. Yes. So these are the conditions wherein you get the dorsal pterygium, that is the formation of pterygium on the surface of nail plate. So these are the dorsal pterygium as already told. So these are on the nail plate. Then where you get the ventral pterygium. So ventral pterygium, I'll show the image. Ventral pterygium is involvement of the hyponychium. So suppose this is a finger, this is a nail. So the ventral pterygium starts here. So it is the involvement of the hyponychium initially, and it fuses with the nail plate. So thereby the ventral pterygium will obliterate this nail groove. So therewith, that is the ventral pterygium. It is seen in leprosy, neurofibromatosis, subungual exostosis, SLE. Remember, SLE can present with both ventral pterygium and dorsal pterygium, and systemic sclerosis. So remember, leprosy and systemic sclerosis, they are quite characteristic of ventral pterygium. So these are ventral pterygium. So these are due to the involvement in hyponychium and their fusion with the nail plate. So these are the ventral pterygium and their involvement in the hyponychium. Question number 4. Yes, 1 is F, okay. 3 is B, okay. So as already told, 1 is F, cordability sign and exclamation mark here, they are characteristic of alopecia areata. Then alternate dark and white bands, they are seen in kwashiorkor, and tonsor pattern, it is a characteristic of trichotillomania. So this is the correct arrangement for the given question. Okay. Now the female pattern hair loss, it presents as widening of hair central part. So this is the central part, so there will be widening of it. So this is the female pattern hair loss. So you know there are 3 grades. It goes with the classification. The name is Ludwig's classification in females. So grade 1, 2, 3. So this is how it is classified. So the clinical image is there beneath it. So the grade 1, when it is widening is less, when it is more, and when it is severe. So this is the various grades. So I'll come to it, the tonsor pattern away. So you know the again the female pattern hair loss stage 1, 2, 3 and advanced stage. Then these are the hair changes in alopecia areata. You get the cordability sign. This is due to the weakening of hair shaft. When pressed inside, they tend to bend. So that is the cordability sign in alopecia areata. These are exclamation mark here, something like this. So these are again seen at the periphery of the lesions, and remember both of them are trichoscopic finding. Both of them are microscopic or magnifying lens finding. They are not seen clinically. So this is to show you the swarm of B appearance, that is a lymphocytic infiltrate in the lesions of alopecia areata. So you know around the hair follicle you get the lymphocytic infiltrates. So this is around the hair follicle. This is the hair in kwashiorkor, alternate dark and light bands. So these are the hair changes in kwashiorkor. Then this is trichotillomania. So trichotillomania, you get the tonsor pattern. What does it mean? It means that the hair at the periphery will be intact. At the periphery, the hair will be intact, but at the central part of the scalp, there will be loss of hair. So in the central part, there will be loss of hair. At the periphery, they will be intact, and it is a feature of trichotillomania. Now, this slide is to show you that the bitemporal recession, though it is very much characteristic of male pattern hair loss, it can be seen in females. So the females, they can present with the male pattern hair loss, and males, they can present with the female pattern hair loss. So it is vice versa. So both can present. So these are the hair in hirsutism. The hirsutism hair, they look something like this. So excess of hair growth in the hirsutism. These are the anagen effluvium changes. They are rapid developing changes. It could be due to the chemotherapy, radiotherapy, protein energy malnutrition and poisoning. So the anagen effluvium, it develops within a month, and telogen effluvium, it takes around 3 months to develop. So this is how these are the few hair changes in dermatology. Coming to question number 5. Yes, it could be away. Yes, all others, please try to answer it. Okay, varicella HHV3. Then, so pityriasis rosea is 3. You know, I'll tell you the answer. The Kaposi varicelliform eruptions, so they are secondary to human herpes type 1. Varicella, they are due to type 3. Pityriasis rosea, it could be both C and D. It could be HHV6 and HHV7 for pityriasis rosea, and Kaposi sarcoma, as already been told, it is due to human herpes virus 8. So this is the correct arrangement for the given question. So you know, the human herpes virus in the skin, HHV1, it is associated with herpes, it is also called as herpes simplex virus, associated with Kaposi varicelliform eruptions. I'll tell you what are they. Then HHV2, they are associated with genital herpes. HHV3, it is also called as varicella zoster virus, associated with varicella or herpes zoster. HHV4 is Epstein-Barr virus. HHV5 is cytomegalovirus. HHV6 is associated with exanthema subitum or roseola infantum. HHV7, it is associated with pityriasis rosea, and HHV8, it is associated with Kaposi sarcoma. But now I want to tell you that both HHV6 and HHV7, they are associated with pityriasis rosea, and they can be associated with roseola also. So both HHV6 and HHV7, they could be the cause for the roseola and the pityriasis rosea. Now coming to the numbered exanthems, the first disease is measles, second disease is scarlet fever, third disease is the name given to rubella, fourth disease is Duke's disease, but it is not commonly accepted as different entity. Fifth disease is erythema infectiosum, and sixth disease is exanthema subitum or roseola infantum. So these are numbered exanthems. Now coming to Kaposi varicelliform eruptions. So in Kaposi varicelliform eruptions, initially there will be underlying inflammatory diseases like atopic dermatitis is commonest of them. So the child will be having atopic dermatitis. On top of the atopic dermatitis patches, you get the development of herpetic lesions. So primary episode will be an eczema, and on top of eczema you get the development of herpetic vesicles. It is usually seen in infants with atopicity. It is associated with development of multiple painful vesicopustular eruptions. There can be superinfection with Staph aureus or streptococci, and the primary infections apart from atopic dermatitis can be pemphigus, it could be mycosis fungoides, Darius disease, Haley disease, and various type of ichthyosis. So it is very commonly associated with atopic dermatitis. It is a complication of atopic dermatitis. Child will have an eczematous patch. On top of that eczematous patch, there will be development of vesicles secondary to herpes simplex. So these are Kaposi varicelliform eruptions. So they are also called as eczema herpeticum. So they are also called as eczema herpeticum. Now few more images. So these are the Kaposi varicelliform eruptions. So initial episode will be an eczema. On top of it you get the pustule vesicle secondary to herpes simplex virus, and similarly here you get the vesicle secondary to herpes simplex virus on an underlying etiology of atopic dermatitis. Then what is eczema vaccinatum? So in atopic dermatitis, smallpox vaccination or even exposure to vaccinated individual may cause widespread eruptions like the Kaposi varicelliform eruptions or the eczema herpeticum. So but the eczema vaccinatum, it is due to smallpox vaccination or even exposure to a vaccinated individual, you get the development of lesions, similar sort of lesions. So that is called as eczema vaccinatum. It resembles eczema herpeticum. So the term Kaposi varicelliform eruptions, it includes both eczema herpeticum and eczema vaccinatum. So in herpeticum or atopic dermatitis, it is HSV infection, but eczema vaccinatum on atopic dermatitis, it is exposure to smallpox, individual with smallpox vaccination. So eczema herpeticum, it is due to HSV1, and eczema vaccinatum, it is due to vaccinia virus. Question number 6. Probably it's going to be the last question of today's discussion. Hi Goranga. So Abhay says 2 is C, that is 2 is measles, strawberry tongue is with D, 1 is with F. Then what happened to 4? 2 is C, 3 is D, 1 is F. Yes, very true, Abhay. For shimmer spots, they are seen with rubella. Koplik spots, they are seen with measles. Strawberry tongue, they are associated with Kawasaki disease. And Nigayama spots, they are characteristic of Roseola infantum. So ananthems are the lesions in the oral cavity. So I'll show you the clinical images of all of them. So these are Nagayama spots. So these are, they may involve the soft palate, so erythematous papules over the soft palate and uvula, and may present with palatoglossal ulcers. So these are inside the oral cavity over the soft palate and uvula. The strawberry tongue, as you can see, the strawberry appearance of the tongue. So it is due to the tongue with marked redness and prominent gustative papillae. So the papillae will be prominent in the strawberry tongue. So thereby it gives an appearance of a strawberry. So these are Koplik spots. So you know Koplik spots are very much characteristic of the measles. So these are grain of sand with erythematous halo. So this is the characteristic term used, grain of sand with erythematous halo over buccal mucosa opposite second molar. So this is opposite second molar. So they are the Koplik spots are very much characteristic of measles, and these are Forsheimmer spots. Again these are erythematous macules over soft palate and uvula. So the Forsheimmer spots are seen in the rubella. So they are again the involvement of the soft palate and uvula. They are the clinical manifestations, the oral manifestations in the on the uvula in rubella. So I'll take one more questions before closing the session. So you have to identify the bodies and you have to arrange them according to the diseases in which they are found. One is A, 2 is F, 3 is C, 2 is E. So Goranga says 1 is A, 4 is E, 2 is C, 3 is C. Okay, partially, if all of you are partially correct. So 1 is A, that is sclerotic bodies in chromoblastomycosis, that is the correct arrangement. So 2, the asteroid bodies, they are seen in sporotrichosis. Sporangia, they are characteristic of rhinosporidiosis. and grains, they are seen in mycetoma. So this is the correct arrangement for the given question. I'll show the bodies to you. Yes, medullary bodies, they are also called as. So these are sclerotic bodies in chromoblastomycosis. So these are something like this, the sclerotic bodies of chromoblastomycosis. These are asteroid bodies in sporotrichosis. These are sporangia in rhinosporidiosis. And lastly, these are grains of mycetoma. These are nothing but the fungal colonies. So this is what I have to tell you in today's YouTube session of the match the following type MCQs in dermatology. I'll come once again tomorrow at the same time 1:30 p.m. with few more questions, that is the sequential arrangement type of questions in dermatology. So I'll be presenting the newer pattern of MCQs in dermatology. I won't be asking the regular pattern of, I may be taking it in the last, the regular pattern of single most common type of answer in dermatology. So I'll be doing, yes, I'll be doing the newer pattern of questions in dermatology initially. So I'll come back once again at 1:30. So with this, I'll thank you for your patient listening and I wish you good luck for your examination. So thank you very much, and I would like to see you again tomorrow at 1:30 p.m. in the at the same time in the some more, and I'll be presenting some more questions in dermatology that will be on sequential arrangements in dermatology. Thank you very much for patient listening. Thank you.